Welcome to the Senate Commerce and Consumer Protection Committee, March 6, 2025. Appreciate everyone being here. Today is Mandate Day. Just a few introductory remarks on this before we get to the bills. Each year, this Commerce Committee and the HHS Committee field submissions from legislative members in excess of 20 sort of proposed mandates on our insurance plans in the state of Minnesota. Each one of these on its own face is meritorious and seems like something we should be doing for health of Minnesotans, but collectively they increase the costs of health care for Minnesotans everywhere. We already have over 70 mandates on the health plans in Minnesota. I believe that's the most in the country, and they collectively increase the cost of premiums for every single Minnesotan who tries to buy health insurance. I bring to our Mandate Day every year a few principles. Number one is that I've trimmed the over 20 submissions we've received so far down to 3. Again, with that same lens of being conscious of costs for healthcare of Minnesotans and being conscious of which benefits are truly essential to public health. I also insist that every mandate that we propose and pass through this committee applies not only to our private health plans, but also to our public health plans. The philosophy there being, if we really think something is so good and so essential for health of Minnesotans, that we should require our plans to cover it, why it only makes sense that we should require public programs to recover it as well. And lastly, I each year include a hearing for Senator Frentz to propose a defrayal bill, which was how we will start today. And that is the idea that if we're going to increase costs for premiums in Minnesota by adding mandates to health plans, we may want to defray those costs through the Department of Commerce, through taxpayer dollars, so that individual Minnesotans don't see a rise in their health care costs. Every bill that is on the agenda today will be passed through to HHS, Senator Wickland's committee, where she has shared jurisdictions over mandates. And with that, we will go to Senate File 565. Members, in your packets also, we did not include a presentation on mandates writ large by the Department of Commerce this year. This was done in the House, but the handouts from those presentations are in your packets. There are also 62G evaluations on every mandate that we've proposed within the packets. Senator Frentz, welcome to the committee. Senate File 565 is in front of the committee.
Thank you very much, Mr. Chair. Thank you, members. I come before you again to talk about the issue of health care costs. I represent District 18 with over 2,000 family farms, many of them in the individual market. One of the top things I hear every year is, why are my premiums so high? I bring you this defrayal bill as a way to address the issue of increasing number of mandates. It's not necessary for us all to agree on this, but I think we can all agree. The message voters sent in November is that they're very concerned about daily costs, weekly costs, monthly costs, and for a farmer and his family to pay $1,600, $1,800 a month for health care just for the premiums is starting to become more of an issue. Mr. Chair, you've been a champion for us discussing the issue of costs, and into that, just like to share with the committee members a few reasons why I think we should be a yes vote on Senate File 565. First of all, let's take stock of where Minnesota is. As the chair mentioned, we have the most mandates in the country. It is always good to provide health care for someone who needs it. It's a separate question, at what cost? Other states have been able to keep the mandate list lower, and what this bill basically does is says that the Department of Commerce, with taxpayer money, will help defray the cost, preventing a new mandate from increasing the monthly premiums. Insurance is very simple. Premiums come in, claims go out. We have an issue, Mr. Chair and members, about where do we want Minnesota to rank in terms of the cost of health care. As a member of the greater Minnesota delegation, I'd also say we have some rural hospitals that have some issues, including in particular my district, St. Peter, and also Winona. So I think the cost is the kind of issue we have to get into every session, and I think we have to be serious about it. Minnesota has the 9th highest family premiums in the country. Think about that. Out of 50 states, only 8 have higher premiums than Minnesota. That's starting to be an issue. Minnesota has also a pattern of reviewing the mandates, which has generally led to us increasing the mandated coverages. If you are a family whose family member needs that treatment, that is a good thing. However, we share that cost, and that's got to be a factor. It does not have to be the only factor, but it has to carry equal weight. Minnesotans are asking us, what is the cost of living? We have talked about the way the health insurance mandates are treated in Minnesota, Mr. Chair. I'm happy to defer to your lead on those discussions about what mandates meet the cost. But if we are passing Senate File 565, we will at least pause in a significant way before a mandate is put on the state of Minnesota and its ratepayers. I have with me Mr. Bentley Graves from the Minnesota Chamber of Commerce. Mr. Chair, I hope it'll be okay for him to offer some testimony.
Senator Frentz, we do have both Dan Andreessen and Bentley Graves listed as testifiers. I see Mr. Graves at the table. Please introduce yourself and proceed.
Thank you, Mr. Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. We're the state's largest business trade association. We represent more than 6,000 employers across the state in every corner of the state and every industry and in every size of business. Thank you again for the opportunity to testify on this important bill. Health insurance is an incredibly important benefit in this competitive labor market. It allows employers to attract and retain talent and helps ensure their employees stay healthy and productive at work. About 70% of our members provide health insurance to their employees. 3/4 of them do so through the state-regulated, fully insured market. This allows these mostly small and mid-sized businesses to provide coverage to their employees without having to take on the financial risk of a self-insured, self-funded plan. But as you heard, it also comes with one of the longest lists of mandated benefits in the country. Each of these benefits was put in place to help people. There is no question about that. But each also comes with a cost. Because of this, we have long encouraged the legislature to show restraint when proposals are brought forward to add new mandates to state statute. But admittedly, this is a tough ask. Since 2022, however, we've had a new mandate benefit review process in place, which requires the Department of Commerce to perform a cost-benefit analysis for new mandate proposals. This new process has helped all of us better understand the trade-offs that come with new mandates. But in doing so, these evaluations have repeatedly confirmed the fact that there is a cost associated with mandates. And that's a concern, because healthcare affordability for employers and their employees is not getting easier. Roughly 3/4 of our members who currently offer health insurance tell us they'll be forced to make significant changes to their offerings, including reductions in coverage and dropping coverage altogether if costs continue to increase at the current rate. Some have already had to make this tough decision. 1 in 5 chamber members who don't currently offer health insurance tell us it's because prohibitive cost increases force them to drop the coverage that they had. Fortunately, the bill before you today will help address one aspect of rising health insurance costs. There are many components of the cost of health care that are outside the direct control of the legislature, but only the legislature can add new mandates to the health insurance sold in the state. So, when policymakers decide that there is a public health imperative for additional benefits, Senate File 565 offers the state the opportunity to invest in the health of those seeking them, while also ensuring costs for those who rely on coverage in the state's fully insured market don't increase as a result. For that reason, we thank Senator Frentz and Senator Dames for bringing the bill forward, and we thank the committee for its consideration today. Happy to answer any questions you may have, Mr. Chair. Thank you.
Thank you, Mr. Graves. Mr. Andreessen.
Good scene. Thank you.
Welcome to the committee. Please introduce yourself and proceed.
Mr. Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans, representing the nonprofit insurers here in Minnesota. Thank you for the opportunity to testify today in support of Senate File 565. Trying to tackle the increasing cost of health insurance has been an ongoing struggle here at the legislature. Last month, the committee discussed continuing the state's reinsurance program as one of those solutions. Senate File 565 is another solution to address the growing cost of health insurance in the fully insured market. Now, there are several factors that impact the cost of insurance, and one of those is the amount of services a policy is covering. When a health plan creates a policy, it estimates what's going to be the total cost to pay all covered claims for a given population with a certain coverage benefit set. Health plans use premiums collected from enrollees to pay for healthcare delivery, pharmaceuticals, medical equipment, and others to treat these covered services. Meaning the more services a health plan is required to cover, the more premiums will be needed to be collected from enrollees and create policies that would increase cost sharing. Now, we understand the reason for a new mandate is sought. It's to help somebody struggling with a medical condition. Treatment for that condition, however, has a cost. And if a mandate requires now a health plan to help pay for those costs, we will need to collect that new amount from policyholders. Mandates increase the cost of insurance in the fully insured market, which along with Medicare and Medicaid Medicaid and MinnesotaCare are the only markets that are impacted by any new mandate. Over the past few sessions, we've seen a significant increase in the number of coverage mandates. Since 2014, 20 new coverage mandates have been enacted. Of those, 13 were passed the last 2 years and went into effect this January. Now, for some of these mandates just on their own, the financial impact of them is pretty low. However, when you put them all together, the impact can be significant. Collectively, for our members, we've determined that premiums have increased 2 to 5% because of the mandates that have been passed. This equates to around $15 to $25 per member per month in this market. So for a family of 4, that's an extra $1,200 a year. So far this session, 20 new mandates have been introduced, and you'll be considering 4 of those today, which all pose a different type of financial impact to the market. Senate File 974 regarding power standing systems, this would be an expansion of current coverage for our members, so that would add some premium cost. Senate File 1054 regarding vasectomies, our members currently cover vasectomies, but it may depend on what product you buy. You may have some cost sharing associated with that. This bill would remove that cost sharing, and so that cost would move either into premiums or cost sharing. Senate File 1085 regarding maternal mental health programs. We're still trying to determine the impact of this one and the larger involvement of health plans in mental health delivery, but this would probably also add in a cost. And then Senate File 205 regarding prior authorization of chemotherapy medications. We certainly recognize the public concern over the use of prior authorization. It's also a tool that is used to study safety as well as mitigate costs of certain benefits. Now, for this benefit, chemotherapy drugs can be pretty dangerous stuff. And so PA in this case is a double check to make sure that what is being prescribed is safe for that patient. But these treatments also have significant amount of costs. If these treatments cost $5, the PA for it would probably be a lot different. But these are drugs that cost tens of thousands of dollars per dose and could lead to hundreds of thousands of dollars in costs for a patient throughout the year. So if the goal is to reduce the use of prior authorization, reducing the prices drug companies charge for these medications, which are life-saving treatments, would make a big difference. And certainly these drugs have a cost when it comes to R&D and manufacturing, but I think there's also concern that the costs or the price that drug companies set for these is also regarding their own profit. If the legislature chooses to enact these mandates or others, enacting Senate File 565 will mitigate premium increases of these proposals and any mandates in the future. That would apply to all of them except for the prior authorization bill. Now, an advantage of this proposal is that the mechanism to process cross defrayals is already in place. Currently, for mandates, the Department of Commerce deems is eligible for defrayal. Health plans submitted evidence of paid claims from a previous plan year, so the only time defrayal ever happens is if there was a verified claim that was paid. Defraying the cost of any new mandate is another method to subsidize the cost in the fully insured market. 99% of the coverage in this market is covered by nonprofit health plans whose margins are around 1 to 3% year over year. The council thanks Senator Frentz for all of his work on this proposal over the last few years and urges the committee's support of this proposal. Thank you.
Thank you, Mr. Andreessen, and for consolidating your comments. I think not just on 265 or 565, but also the other mandates that are coming for us, so we won't call you back. That is the end of our testifiers. Are there any members of the public who wish to testify on this bill? Any members of the committee who have comments or questions on 5? Senator Wickland.
Well, thank you, Mr. Chair. Senator Frentz, I know we've had a lot of discussions about this bill over previous sessions, and I'm not any more in favor of it this year than I was in previous years. I really have strong concerns about what this bill would do to our ability to fully explore and address where we see gaps in what people are able to access in terms of insurance coverage. I think we have in place today all the tools we need to assess mandate requests. Not to say that the processes can't be improved, but we do have a way to gather information. We gather information on the costs, and we also have the tools to address defrayal, and we have done that. What this bill, to me, seems to be doing is kind of taking away one of our prerogatives to be able to evaluate a proposal and make a determination fully about the impact on our budget. And then it just sets in motion this idea that payments must be made to the healthcare companies to defray the costs. I don't think that that's going to help Minnesotans. I don't think it addresses healthcare costs, the underlying costs of healthcare. And I think that when we talk about access to care, it goes beyond, your health insurance. If your health insurance doesn't cover the things that you need to stay healthy, that's going to affect our economy as well if people are not, as well able to work, or it takes them away from the workplace. So I think that this bill, it's stated that it's helping business control costs. But I think in the end, having people not be able to access insurance that covers the things they need, that will affect their lives going forward. So I'm glad that this bill, along with the others, will come to the HHS committee if it does pass, and look forward to more discussion about it. But I do have some serious concerns about just the way the mechanics of the bill would work in practice. And like I say, I think we have the tools necessary, and we do have the ability as a legislature to make determinations whether we're going to hear a mandate bill or not. And Senator Klein has just spoken about his process for making that decision. And we can do that as legislators and decide what should move forward. But I don't think we should be constrained by a law that says that the only way that these get evaluated means that we must pay defrayal. So those are my thoughts. I guess I don't have a specific question in there, but thanks.
Senator Frentz.
Thank you, Mr. Chair, and thank you, Senator Wickland. I have the deepest respect for the work you do both here in Commerce and on your committee. Just briefly, the evaluation of the mandate and the cost is exactly what I'm asking this committee to consider, and I respectfully disagree that this would change our ability to evaluate. What I see is this bill says if we're going to approve a new mandate, something we do with some frequency in Minnesota, it will be brought to Commerce for defrayal. And I think I would ask the committee this simple question: is there some reason we don't like that approach? Is there something about Commerce working on defrayal that is unacceptable to us that we would then tell a farmer in Nicollet County, we don't want to pay it, but we want you to pay it? I'm with all of you on the issue of cost. And I think, finally, I would put it this way. My intent, not being a doctor, not being an insurance specialist, just being a Minnesotan, is to make it more difficult for us to approve all the mandates that come through without serious consideration about who's talking and who's paying. We are very familiar, I think of Senator Dietzick and her work on WIGs as a mandate, which was widely supported, with the idea that we're going to do something that makes it when a Minnesotan needs that to be covered, it is covered. We know that satisfaction of providing the opportunity to say that's covered. What I think we lack a little bit in the state legislature right now is to equally consider that moment when the payer of the premium gets their bill and access to care becomes a question of, I can't afford this, and do we change the number of people in Minnesota who are covered? So I'm with you, Senator Wickland, on access to care being important. I ask Mr. Chair for support of the members in sending this bill on for further discussion. And that is really where we're coming from here, which is only to say, at what point would we want to slow down the approval of the new mandates?
Senator Duckworth. Oh, sorry, Senator Wickland.
I just, thank you, Mr. Chair. I just wanted to say, I don't see this as negatively impacting the ability to evaluate. So it does allow us to evaluate. What I'm saying is that it does put a constraint on the legislature, which is what you've indicated you wish to see happen. And I don't think that we should be putting that constraint in law like that. I think we have the ability to be able to form our opinions with the evaluation process that we have right now.
Apologize for cutting you off. Senator Duckworth.
Thank you, Mr. Chair. I appreciate it. And Senator Frentz, I appreciate the discussion so far and then the perspective you've shared. I feel like it's a perspective that many of us have subscribed to for many years and have maybe shared from these very seats when we've talked about some of the mandates that have now become law for the very reasons that you mentioned. Ultimately, the consumer ends up paying a higher premium in regard to their insurance. So I understand the thought process behind a defrayal and the government stepping in and providing some money to offset the costs associated with insurance mandates to help keep the price low. But I also think, as was mentioned several times here today, we acknowledge that Minnesota is a leader in the nation when it comes to the number of insurance mandates, and then we quickly follow that up by saying we're also one of the highest when it comes to insurance premiums. I think those two things go hand in hand. And there are a couple of ways that we can keep insurance premiums low for the people of Minnesota or provide them more choice, and some of that has to do with the mandates that are on the books. And so while I appreciate where this bill is coming from, and I am open-minded to it, one of my concerns is that if we pass this, we're kind of signaling, bring on the mandates, bring even more, because the government's going to subsidize them. And when the government subsidizes them, that means the taxpayer does. So in order for us to be able to afford the mandates we want to impose on folks, and in order to keep your insurance rates low, we're just going to increase taxes on you. I see you shaking your head. Because if the state's going to have to pay the bill, they have to get the money from somewhere. And we learned today the state doesn't have a whole lot of money right now. They're actually billions of dollars in the hole. And that's, I think, a part of the conversation more holistically. How many mandates are we going to put in place here in Minnesota that ultimately trickle down to the consumer, whether it's through their insurance premiums or the tax dollars they're having to surrender to the state of Minnesota to cover those subsidies? That's all I've got, Mr. Chair. Thank you.
I'll let Senator Frentz respond, but I can't resist responding just a little bit myself, which is if Senate File 565 was to pass and we were to hear the same three mandates that are being proposed today, each one of them would come with a fiscal note, which would add a little bit of salt to our propositions here. We'd all have to think about what's going to be the target for the Commerce Committee, and do we want to spend X dollars on vasectomies? So that's my purpose in supporting the bill. Senator Frentz.
Thank you very much, Mr. Chair, and thank you, Senator Duckworth. I think we want the same thing. My vision of Senate File 565 is something like this. If we have to have a fiscal note, we are less likely to miss what should be a new mandate and what shouldn't, and less likely to put on the individual ratepayer something that maybe wasn't the best reason. We come here and put these new mandates on, and the public is allowed to testify, but 98% of the public is busy putting a roof over their heads, clothes on their back, and food on the table. And so what I'm saying here is it should be a tough conversation for a new mandate. And I think the reason why I wonder if this would lead to less mandates is because of the fiscal note that the chair is referring to. I don't want to increase taxes. I think what I want is to say, if you're really going to put a new mandate on, you better be ready to back it up. And again, I ask, if we're going to make a new mandate, who's paying it again? And when are they going to feel that pain? Because what I'm getting now is they feel the pain when they get their monthly health insurance premiums. So bottom line, if we have to have a fiscal note, mandates are harder to pass, and I think that's appropriate. And I would add, those in the individual market of Minnesota, I think would be standing up and clapping right now saying, let's put the brakes on mandates. If we're not willing to pay them through the defrayal process, what do you want us to pay it for out of our hard-earned paycheck every month?
Other comments from the committee? Senator Duckworth.
Just a quick follow-up, Mr. Chair. Point well taken. The only thing I would add is there's nothing stopping us from having those same conversations, although they may be difficult, from mandates that have recently passed and are already on the books that maybe came with some higher fiscal expenditures than we initially thought. So I agree with your methodology and your reasoning here, and yours as well, Mr. Chair. But if that's a route we're going to go as a state, we got to look in the rearview mirror as well.
Other questions or comments from the committee? Seeing none, the motion is Senator Frentz that Senate File 565 be recommended to pass and referred to the Committee on Health and Human Services. All in favor, say aye. Aye. Opposed? Motion is adopted. Thank you, Senator Frentz. Senator Mann. Do all of these have amendments?
Hello, Senator. Nice to see you.
Senator Mann, you're going to be there for a little while. So get comfortable. We are starting with Senate File 205. I'm checking to see if you have an amendment. You do. Senator Senator Rest offers the A1 Authors Amendment. All those in favor say aye. Aye. Opposed? A1 is adopted. Senator Mann.
Thank you, Mr. Chair. So Senate File 205 is the bill that was drafted last year by Senator Dietzich after she personally encountered the kind of scam that has become the prior authorization process. She wrote an op-ed where she was billed $100,000 for her chemo treatment that was ultimately approved, as most prior authorization denials ultimately are. Of course, this was after time and paperwork and stress, which is just what you need while you are undergoing cancer treatment. Oncologists will tell you that once a diagnosis of certain cancers are made, treatment starts tomorrow. There is no time for a prior authorization. Treatment often starts despite lacking a go-ahead from your plan because you don't have the time for a prior auth, which puts a lot of stress on the patients and on their care team, especially when in many cases, the treatment is the standard of care. 1 in 5 physicians will tell you that they have experienced a situation where a prior auth delay has led to a life-threatening situation for a patient. And the time spent on prior authorizations amounts to over 13 hours per week for the average physician, which is 2 full working days. We just heard that chemotherapy involves some very dangerous drugs. So why would you trust some random person you have never met before deciding what chemotherapy drug you should have instead of your oncologist? Cancer treatment cannot wait, Mr. Chair. That's all I have.
Thank you, Senator Mann. And I don't see any testifiers listed, so we will go to member Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Mann. One question I had is, when I'm looking at the language of the bill, it's obviously changing and building on other previous laws that have been passed around prior authorization, and I was wondering, Mr. Chair, if Senator Mann could talk about why there was this exception in the previous prior authorization bill that has passed.
We will go to Senator Mann, who is pinch hitting for Senator Port, and if you need to call a friend, we can go to council as well.
Mr. Chair, so last year we passed treatment for cancer, which included radiation, but it excluded medications because last year they had a hard time quantifying what that meant. And so for the time, they had excluded it.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Mann. I think everyone on this committee and in the Minnesota Senate want to make sure that Minnesotans who are diagnosed with cancer get the best treatment as quick as possible, and all of us have very likely experienced family, friends who have been diagnosed with cancer and gone through that treatment. And so I think we share the same goals. One of the questions I also had on this bill, Mr. Chair, for Senator Mann is, has this bill or anything similar to it gone through a 62J review process?
I can field that one, Senator Rasmussen. So this is not technically a mandate. It's a modification to prior authorization laws, so it wouldn't qualify for the 62J process. But Senator Mann, you may have.
As far as I know, that is correct, Mr. Chair.
Okay, Senator Rasmussen.
Thank you, Mr. Chair. And do you know if, is there going to be a fiscal note on this bill? Has that been requested? Do we have that back?
Senator Mann.
I'm sure it's been requested. I don't have anything back.
Okay. Thank you. And the reason I asked, Mr. Chair and Senator Mann, the reason I think the way that this committee and our counterpart over in the other body, using the 62J reports, having fiscal notes, helps us understand what this is going to mean for Minnesotans who are paying the premiums. And so I'm just a little concerned that today, we don't have information either in terms of a fiscal note or a 62J review that would talk about what this will mean in terms of cost. And the only data point I do have, Mr. Chair, is actually from Governor Walz's budget recommendation, where he basically recommends eliminating the sunset of the drug formulary committee for the state. And in there, the reason he says that is I'm just reading right from the budget that was put out in January of this year. The Minnesota Department of Human Services would be unable to establish prior authorization criteria to address high-cost drugs and issues of safety and efficacy. And they also go on to talk about how if this committee went away, would result in the loss of hundreds of millions of dollars in rebates to the state. And so even Governor Walz in his own human services budget kind of acknowledges that by limiting or eliminating prior authorization in certain circumstances, that can lead to higher cost. And so I don't know what this cost will mean in this bill, but would definitely feel, Mr. Chair, more comfortable if we had that fiscal note before we sent it out of committee, or if we were even able to get some guidance from Commerce on what this could mean in terms of cost. But again, I think every member of this committee shares the goal of trying to ensure that people get the high-quality care they need in Minnesota, but just want to make sure we have all the information on this bill. Thank you, Mr. Chair.
Thank you, Senator Rasmussen. Other comments or questions from the committee? Just a couple of comments of my own. Senator Mann, thank you for presenting the bill today in lieu of Senator Port. And obviously the editorial that's quoted in our notes from Senator Dietzick is quite moving. But you and I as physicians know that these are some of the most exasperating and unbelievable moments in delivery of medicine when you have a patient who you not only have to inform that they have a new diagnosis of malignancy, and need to proceed urgently to therapy. But then you also have to delay that therapy while they figure out if a very expensive but clinically recommended, task force-based recommended treatment may fall into their own pocketbooks. It's bad medicine. It harms patients. It creates increased stress in a circumstance already fraught with stress. And I fully support the bill, and I thank you for presenting it. So with that, the motion is by Senator Seeberger that Senate File 205 as amended be recommended to pass and refer to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Bill passes. Thank you, Senator Mann. We move now to Senate File 974. And you have the A1 Authors Amendment. Senator Wickland offers the A1 Authors Amendment. All those in favor say aye. Aye. Opposed? Senator Mann, 974.
Thank you, Mr. Chair. 974 is about, will require coverage of power standing systems. A power standing system is a feature on a power wheelchair that allows the user to transition from a seated position to a standing position using motorized mechanisms. This allows the user to better function during the day, executing their activities of daily living, while many times decreasing the need for a caretaker. There are also studies that show potential health benefits, including reduced risk of pressure ulcers and improved cardiovascular system functioning, both of which have significant healthcare costs and impacts of quality of life. This bill was also drafted last year by Senator Dietzick, as she learned firsthand what it was like to need a piece of equipment that was recommended by your doctor to increase her independence and to decrease her risk of complications, and to have that piece of equipment denied. Having this piece of equipment will decrease morbidity by decreasing rates of pressure ulcer, which are very difficult to treat, and will save healthcare costs down the line by preserving independence and decreasing reliance on caretaker. When I think of healthcare mandates, I think of three things, Mr. Chair. One is, will it reduce morbidity and mortality? Two is, will it reduce healthcare costs down the line? And three, does it provide a societal good? And this particular bill does at least two of those things. So I think it's a very good bill.
Thank you, Senator Mann. We have a long list of testifiers. Can Julie Piriano and Britta Schwarzkopf please come forward?
Senator.
Ms. Piriano, welcome to the committee. Please introduce yourself and proceed.
Thank you, Chairman Klein, Vice Chair Seeberger, and committee members. My name is Julie Piriano. I'm a physical therapist, an assistive technology professional, and seating and mobility specialist with 41 years of experience. I'm also currently the Senior Director of Payer Relations and Regulatory Affairs for NCART, the National Coalition of Assistive and Rehab Technology. NCART is a nonprofit national association of suppliers and manufacturers of complex rehab technology, products, and services. We focus on education and advocacy with an emphasis on establishing and protecting appropriate coding, coverage, and payment policies to ensure children and adults with significant disabilities and complex medical needs have adequate access to the specialized equipment and related support services that they need. I'm here to convey our very strong support for SF 974 to expand coverage and payment for power standing systems to all Minnesota beneficiaries that have been evaluated by a licensed clinician and supplier ATP for whom this component has been deemed medically necessary and prescribed by their physician. It is a very small subset of the beneficiary population. A small investment in this enabling technology that doubles the functionality of the complex rehab power wheelchair can save thousands of healthcare dollars over its 5-year reasonable useful lifetime. When we consider the benefit of standing and what it has as far as the cardiovascular system, the digestive system, integumentary, musculoskeletal, and respiratory systems. In fact, the average healthcare expenditure to heal a pressure injury is between 2 and 13 times more than the cost of a power standing system. It would be penny wise and pound foolish not to support this measure. We appreciate Senator Mann for bringing this bill forward. And any questions?
Thank you, Ms. Piriano. As you clear the table, could Nicole LaBerge please come forward? Ms. Schwartzoff, please introduce yourself and proceed.
I want to thank you for the opportunity to share today. My name is Britta Schwartzoff, and I am a licensed physical therapist here in Minnesota. I am certified as an assistive technology professional and a seating and mobility specialist, and I'm also a member of the Clinician Task Force. With over a decade of experience, I have worked extensively with standing technology throughout my career and have witnessed its profound impact on the health and function of the individuals that I serve. Prolonged sitting poses serious health risks, earning the phrase, "sitting is the new smoking," and prompting widespread calls to stand more and sit less. However, for individuals with disabilities who cannot stand independently, accessing this fundamental health benefit can be an uphill battle. Consistent supported standing provides widespread health benefits, positively impacting multiple body systems, such as the musculoskeletal, integumentary, cardiovascular, respiratory, metabolic, urinary, and digestive systems. By integrating standing into the wheelchair system, individuals can access these benefits throughout the day, whether at home, work, school, or in the community, maximizing both health and functional outcomes. Take Sarah, a woman with quadriplegic cerebral palsy. With standing technology, she experiences a reduction in her spasticity and her tightness, improving her range of motion and ability to then participate in her transfers, enhancing the safety for both her and her aging parents that care for her. Additionally, regular standing in her power wheelchair promotes digestion and bowel function, impacting Sarah's chronic constipation and reducing the need for medical interventions. Beyond the physical health benefits, standing technology empowers Sarah to be more engaged in daily life, providing mental health advantages. It enhances her ability to communicate, increases her comfort, and supports her independence. I'm thankful for the opportunity to be in support of Bill SF 974, as investing in standing means investing in a healthier life for all power wheelchair users. Thank you.
Thank you, Ms. Schwartzoff. As you clear, could Kyle Walker please come forward? Ms. LaBerge, please introduce yourself and proceed.
Thank you for this opportunity. My name is Nicole LaBerge, and I'm a licensed physical therapist and assistive technology professional who has practiced in Minnesota for over 18 years. I previously served on the executive board of the Clinician Task Force. I have authored multiple peer-reviewed journal articles focusing on power standing systems, the health benefits that they promote, and the secondary complications that they can actually prevent. Throughout my career, I've worked closely with individuals who rely on this technology, and I will share with you the incredible impact that these systems have had. Maria, who lives with quadriplegia, she developed a stage 4 pressure injury on her tailbone, despite repositioning efforts and specialized cushions. Her power standing wheelchair became the only way that she could fully relieve pressure and improve blood flow to this area. Over several months, her wound healed completely, avoiding hospitalizations, surgical interventions, and need for daily nurse visits, which saved tens of thousands of dollars in medical costs. 8-year-old Lucas, he was paralyzed in an accident, and returning to school was difficult. He felt isolated from his peers when he couldn't even stand for the Pledge of Allegiance. With a power standing wheelchair, he was able to rejoin classroom activities. He was at eye level, participate in group projects, and even stand during school assemblies, restoring his confidence and his sense of belonging. After a spinal cord injury, Reverend Thomas struggled to breathe and to project his voice while sitting, making it impossible to continue delivering sermons. When he received his power standing wheelchair, he was able to stand at the pulpit again, expand his lungs fully, and regain his breath control, allowing him to deliver his first sermon since his accident and bringing inspiration and hope to his community again. Despite the overwhelming evidence of their necessity, power standing systems are often denied by insurance, leaving these individuals without access to a critical tool that could improve their health and their independence. SF 974 seeks to change this by ensuring coverage to those who actually need it the most. By passing this bill, you are not only addressing a healthcare need, but you're also upholding the right for those with individuals with disabilities to live with dignity again. Thank you for recognizing that power standing systems are life-changing medical devices that they truly are.
Thank you, Ms. LaBerge. Can Joe Scanlon please come forward? Mr. Walker, please introduce yourself and proceed.
Thank you, Mr. Chair and committee members. My name is Kyle Walker. I currently serve as the Vice President for Reliable Medical. I am an assistive technology professional. I've been practicing in the field for about 15 years. For those of you that aren't familiar with Reliable Medical, we are a post-acute DME provider, and I've been practicing in the state for over 30 years. I also serve as the chair for RESNA's Professional Standards Board, who oversee the ATP, SMS, and RET credential. I also sit on the board of directors for NCART, as Julie indicated. What I want to talk to you guys about today a little bit, I'm going to be relatively informal, so bear with me here. I've had the unique opportunity to see firsthand the impact of this technology on the consumer's life and the constituents in the state of Minnesota. You guys as a state have been the front runners in this technology for traditional Medicaid fee-for-service, and this opportunity to expand it to other insurers that practice within the state will be life-changing for many individuals. In my experience and career, I have the opportunity to sit as a advisory board member of the University of Pittsburgh, who have a health outcomes data tool with over 10,000 data sets in there that supports the provision of complex rehab equipment, specifically standing and other CD technologies for the benefit of those constituents. When an ATP, like myself and other clinicians, are involved in that provision process, the equipment lasts longer. As Senator Mann indicated, and Julie, that their health outcomes are increased. They have a reduction of cost, reduction of falls, risk for falls, decubitus ulcers. You all know how costly admissions or readmission into a hospital is. This technology will almost directly, that's anecdotal, have an impact to the cost and increase in the quality for those constituents. My ask of each of you today and the committee as a whole is to continue to consider this opportunity. If I put myself in the shoes of patients, consumers that have had injuries that would indicate the need for power standing, I can't imagine what it would be like not to be able to stand up and look someone in the eye, dance with my daughter at a wedding, or stand up for the national anthem. So I ask you guys to continue to consider the support of this bill.
Thank you.
Thank you, Mr. Chair.
Yeah, thank you, Mr. Walker. Can Angela Liuzzi please come forward? Mr. Scanlon, please introduce yourself. Proceed.
Good afternoon. My name is Joe Scanlon. I am an assistive technology professional, recently retired after 35 years in the industry with Reliable Medical. I've been able to be involved in procuring this type of equipment for many individuals, and I just want to share a quick story with you about someone who's been using this technology for about 9 years. 9 years ago, I was reached out to by a clinician who had a patient that had worked with me in the past that had multiple stays in the hospital regarding GI concerns. And these were becoming more and more frequently. And the individual had a standing device at home already and was being utilized. And the team had come up with, they thought if there's a way to get this individual to stand more frequently, it could really possibly help reduce hospitalizations. It was a theory. So anyways, we were able to do some demonstrations of the system and showed it to the family. We were able to get it funded by the state of Minnesota. 7 years later, we'll go back now, and the child went from having multiple long-term hospitalization stays multiple times a year to having one hospitalization stay in 7 years. So we're hoping that that chair contributed to that decrease in hospitalizations. It would make sense. It just shows that these, you spend a little bit more money up front, you can save some money in the long run. And we went to get the chair, lasted 7 years. We tried to get another one 2 years ago, and the state ended up approving it right away because they could go back and look at the data stating that the child's hospitalizations were definitely decreased and the potential savings. So if you look at the 2,000-foot view, these systems really can help the overall health of individuals and reduce the cost. Thank you.
Thank you, sir. Can Carly Kurzman please come forward? Ms. Liuzzi, please introduce yourself and proceed.
Thank you, Mr. Chair and members, for the opportunity today to testify in favor of the proposed bill SF 974. My name is Angela Liuzzi. I'm an occupational therapist with more than 20 years of experience serving individuals with significant neurological conditions. I'm also a specialist in the field of complex rehabilitative seating, meaning I now know more about custom wheelchairs than I ever thought I would. In the past decade, I've written over 1,000 letters of medical necessity, asking insurance companies to authorize custom wheelchairs for patients who need them, including the power standing function. I could tell you 100 stories today about what it's like to suddenly become paralyzed, to lose the use of your arms and your hands, or to feel like you might face plant forward because your core muscles won't activate and hold you upright. These are the very situations that my clients find themselves in. And as you know, accidents, illness, and disease do not discriminate. I'll share one story with you about a high school student I worked with who suffered a devastating spinal cord injury during a football game, and he became paralyzed from the shoulders down. His number one goal during his rehabilitation stay was to be able to attend his senior prom. But his greatest fear is that he would have a bowel or bladder accident if he went. Knowing that one of the key medical benefits of standing is the promotion of vital organ function, such as, what our colleagues have talked about, the heart, the lungs, bowel, bladder, we used power standing early in his recovery as a therapeutic tool to help reset these functions, if you will. And so, for example, by prescribing high dosage standing as a primary part of his daily exercise program, he went from total incontinence to developing a predictable toileting routine. And this is what allowed him to go to his senior prom, use the power standing wheelchair while he was there to dance, to walk down the aisle with his date for the senior pictures, and he didn't have an accident. So ultimately, access to advanced technologies like power standing are not only the link between dependence and independence, but a means for preserving the most basic of human dignities. Thank you, Mr. Chair and members.
Thank you, Ms. Liuzzi. Can Robbie Haas please come forward? Ms. Kurzman, please introduce yourself.
Thank you, Mr. Chair and members, for the opportunity to testify today in favor of the proposed bill SF 974. My name is Carly Kurzman, and I'm a licensed physical therapist with a neurologic specialist certification. I've worked at Mayo Clinic and now at Courage Kenny Rehabilitation Institute, helping people after neurologic injuries regain their independence and quality of life. One of the rewarding parts of my job is connecting patients to the right piece of equipment. This truly improves lives and brings joy. One case I want to share is about a woman who lost the strength in her legs due to cancer mets in her spinal cord. She could no longer stand, walk, or live independently. During our 6-week course of working together daily, I determined that a power standing wheelchair would be beneficial and safe for her. I was considering the physiologic benefits my colleagues have outlined already, but also the powerful social and quality of life benefits of standing. When she stood up for the first time and could see herself giving speeches at work, her face absolutely lit up. She was looking forward to giving a loved one a hug, looking people in the eye at social events, making a meal in her kitchen. As an able-bodied individual, it's easy to take for granted these basic dignities. As a physical therapist, I get to provide the opportunity and empowerment of standing, but one of the greatest frustrations of my work is having the equipment that is needed not be covered. We sought insurance coverage for her power chair, but unfortunately, power standing was non-covered by policy through her commercial plan. By passing this bill, we'll help all other Minnesotans who are not able to access this life-changing and enabling technology without this bill. Thank you, Mr. Chair and members, for your time and consideration.
Thank you, Ms. Kurzman. Ms. Haas, please proceed.
Good afternoon, Chairman Klein and members of the committee. My name is Robbie Haas, and I am also an assistive technology professional and certified rehab technology supplier. I'm employed by Handy Medical Supply. We're a family-owned business located in St. Paul, and we've proudly called Minnesota home for nearly 36 years. I've been there 22 of those. If you could just take a moment and visualize yourself in this chair in your kitchen. Now visualize yourself trying to make breakfast from a wheeled chair in your kitchen. Could you, from this position, turn on the faucet to get the water to make your coffee? Could you reach something in the refrigerator that was placed pretty high? Would you be able to fully make a nutritious meal from that seated position? Could you make eggs for breakfast without fearing third-degree burns on your forearms from the pan? Most likely not. I have witnessed goals being met that include those types. And quite frankly, dreams come true from users of power standing chairs. This includes watching a mom pick up her baby from the crib for the first time. A teenage boy with Duchenne's and who wanted to use the urinal next to his dad and like all of his buddies. A paralyzed auto mechanic who could stand to work on a vehicle and pay his own insurance premiums. Power standing chairs provide independence and opportunities for those who need it the most. Citizens have the right to take a stand. Thank you for supporting Senate File 974.
Thank you, Ms. Haas. That's the end of our testifiers. Before we go to member questions or comments, are there any other members of the public who wish to speak to the bill? I'll just preface our committee discussion by saying Senator Dietzick, as she often did, anticipated some of the conflict we've had on this committee about this and included defrayal within the language of her bill at line on page 3. So defrayal is already included in this bill. Senator Rasmussen.
Thank you, Mr. Chair. And I was going through the 62J report on this, and it talks about how they're estimating that the full defrayal cost in the first year will be between $400,000 and $1.5 million, and that there might be additional costs for the Minnesota healthcare programs. Mr. Chair, could you, in terms of thinking about budget targets, will these mandate benefits apply to our committee, Senator Wickland's committee? Will they be split, or could you just share how potential costs for a bill like this might be accounted for? Thank you.
Sure, and that's the reason that Senator Wickland and I have sort of worked out the arrangement we have on mandates. The full anticipation is that all fiscal costs for mandates will be borne in the HHS budget, and all of these bills will require a fiscal note and a target within that committee, so. Further questions or comments, Senator Green?
Thank you, Mr. Chair. I see that the appropriations are left open. We've got an estimate on the cost. Can anybody tell me how much the chair itself costs? I know I tried looking it up, and there's a wide variety of range of what they cost. So what are we looking at as far as the payments on those?
Senator Mann or one of your testifiers? Welcome back to the committee. Please state your name again and go ahead.
Julie Periano. The chair itself is covered. This is a component used in conjunction with the medically necessary chair. And so when we look at the average MSRP for this component, it's right around $11,000. But that's MSRP. That's the publicly available information.
Senator Green.
Thank you, Mr. Chair. The reason I asked that question is because I've dealt with some of this before, and I'll give you one particular case. It wasn't on a wheelchair, but it was on a lift chair. And I had a friend of mine who was elderly, and he needed a lift chair. And when he went in to try to see what it would cost, he had some insurance, and then he also had Medicare. And the cost of the lift chair was covered under some of the programs 80%. And so when he went in and told him that he had insurance and that the state would be paying for part of it, his share of the cost of that chair was $800. So he went in to the manufacturers of the chairs, or the place where he could buy them, and he bought the chair on his own for $800. And one of the concerns I have is, you're looking at $11,000, and sometimes when we get involved in these things, the cost, because the state is involved, or because the mandates are there, the cost of the chair in this case goes up exponentially. And so is there any price comparisons that you might have, or any, what is the state paying for the chair now without the apparatus? Do you have any of those figures?
Ms. Periano.
I'm sorry, I didn't realize that you were going to look for that information, but I can certainly get that to you. When it comes to the billable codes associated with the chair, there's an associated fee schedule already established for the items. In this case, for power standing, there's not a dedicated fee schedule. So the chair and the other power seating components that would be medically necessary have a code, have a reimbursement rate in establishment. For the power standing system, my understanding is that the Medicaid program manually prices that item currently, meaning that they take a look at it. The state plan amendment probably has a manner in which manually priced items are priced or reimbursed. So in some states, that would be MSRP minus a certain percentage. In other states, that's the primary discount plus or minus. And in other states, on occasion, it's the supplier's acquisition cost plus a percentage. So I'm sorry I wasn't prepared to have that information, but I can certainly get that to you. When it comes to being able to acquire this type of product on your own, like the person that did, I'm a little surprised that was able to happen, but it does. Desperate times, call for desperate measures by certain people, and we will find, chairs that might be available on the internet through Craigslist and eBay and a number of other ways in which an individual could acquire it, which concerns me as a clinician and as a certified professional in this space, because these chairs are designed to fit and function for the one person that it is being recommended for. There are extensive measurements of the person that's going to use it so that all of the moving components align with the moving parts of the human body. And so it is a thorough evaluation by a licensed clinician in conjunction with a supplier, assistive technology professional who would set the chair up in a sort of a preset situation and allow that individual, that beneficiary, to trial the chair in their environments of use if they can. If they're in a rehab facility, then it's in the rehab facility. But there's a trial of the equipment to make sure that what's recommended isn't contraindicated, medically inappropriate, or going to cause harm to that person, and that the cost-benefit, the benefit category is where, the recommendation then lies.
Senator Green.
Thank you, Mr. Chair, and thank you for that explanation, but I think you kind of missed my point. I'm not saying that the chair is invaluable. I'm saying that when we start mandating, or once something is covered, if whatever can be charged will be charged, and the competition goes out of the process. And in the case of this chair, it's specialty. So I wasn't talking about the chair. The chair I was speaking of was a standard lift chair. And so the difference in the competition is that once the government gets involved and once we say, here's money for this, then we don't have any control over what they're going to charge. And so that does worry me. The mandates worry me. And I think you already stated that the state already does pay for the chairs, so if they want to acquire them.
Further questions or comments from the committee on the bill? Senator Frentz.
Thank you, Mr. Chair. Thank you, Senator Mann. I'm a yes on your bill. Just want to follow up Senator Green's point and just pose this for the committee. The cost-benefit analysis is what we're doing, and I think rightly so. Trying to ask, is the cost of this worth the benefit to Minnesota? I just want to pose it this way. Let's make sure that when we do the cost-benefit analysis, the people that are paying the cost are the ones that make that judgment. In other words, it's one thing for the Commerce Committee to say, I've decided it's in Senator Duckworth's interest to have him pay for a mandated service or benefit. I think what I'm looking for in the committee and then for the state legislative process is to say, who is it that's paying and how do we bring their voice into that discussion? If we're going to take our own wallets out of our pocket and make that payment, now you are really doing a cost-benefit analysis of the people who bear that price. I think we're doing great work here. Now that we sit here, Senator Mann, I kind of think Minnesota should have a few more mandates than other states. I think that's in our nature in Minnesota, and I'm a yes on your bill. But I do want to ask members, how do we bring the voice of those that are actually doing the paying to this decision-making process? When they're at the table with their wallets, then you know you've really put it to the test. Thank you.
Further questions or comments from the committee? The motion is by Senator Frentz that Senate File 974 as amended be recommended to pass and refer to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, Senate File 1054. And you have the A1 author's amendment. Senator Seeberger offers the A1. All those in favor say aye. Aye. Opposed? To your bill, Senator Mann.
Thank you, Mr. Chair. Senate File 1054 require coverage for vasectomies, which is a minor office surgical procedure that is 99.9% effective. Again, when I think of mandates, I think of three things. Will it reduce morbidity and mortality? In this case, yes. When men are able to get a 20-minute office procedure versus their partners getting the alternative, which is an intra-abdominal surgery, which comes at greater risk, you absolutely decrease morbidity. Will it reduce healthcare costs down the line? Absolutely. When you have, again, an intra-office procedure versus an intra-abdominal surgery in an operating room with a surgeon and an anesthesiologist, which is significantly more expensive, it decreases cost. And does it provide a societal good? Of course, preventing unwanted pregnancies is absolutely a societal good for everyone. So this one, to me, Mr. Chair, is a no-brainer. It is cheap. It fits all three criteria. And with that, we have some testifiers.
Thank you. We do indeed. Can Sarah Gangelhoff and Andrea Johnson please come forward? Welcome to the committee. Ms. Engelhoff, please introduce yourself. Proceed.
Thank you, Chair Klein and members of the committee. My name is Sarah Gangelhoff, and I'm the Director of Advocacy and Innovation at the Women's Foundation of Minnesota. Thank you for the opportunity to support Senate File 1054. I'll also be providing testimony later on this morning, so you'll see me again. This is because the Women's Foundation believes that Minnesotans should have access to the services required to support their families' health care decisions. Requiring vasectomies to be covered at no cost is not just about expanding access to a medical procedure. It's about closing a glaring gap in our healthcare system. Vasectomies are a procedure that often get overlooked in health discussions, despite being a safe, permanent, effective, and minimally invasive procedure. The imbalance of this discussion sends an outdated message that contraception is solely a woman's responsibility. This antiquated idea has led to women often bearing the physical, emotional, and financial burden of contraception, from pills and IUDs to surgery. However, women in our state also face access barriers for even these options. In our Status of Women and Girls report, we found that in 2022, about 12% of Minnesota women, 283,000, resided in a contraceptive desert where they lack sufficient access to health centers offering a comprehensive range of contraceptive methods. Fully covering vasectomies helps redistribute that responsibility, providing balance in health care, empowering men to make responsible choices, and supporting women who may face side effects, health risks, or access barriers to hormonal birth control or tubal ligation. From a fiscal standpoint, vasectomies are a cost-effective solution. A one-time outpatient procedure, as we've heard, is significantly less expensive than long-term contraceptive methods. Studies consistently show that investing in health solutions like these leads to long-term savings for healthcare systems. By passing this bill, we would join other states who believe in equitable healthcare. It's a matter of fairness, fiscal responsibility, public health, and personal freedom, and we urge you to support this bill. Thank you.
Thank you, Ms. Gangelhoff. Dr. Johnson, welcome to the committee. Please introduce yourself.
Thank you, Chair Klein and members. My name is Dr. Andrea Johnson. I'm an obstetrician gynecologist at the University of Minnesota, and I'm here on behalf of the Minnesota section of the American College of Obstetricians and Gynecologists, and I'm here to speak in support of Senate File 1054, mandating insurance coverage for vasectomies. As an OBGYN, my patients don't typically get vasectomies. However, many of my patients state that they plan to use vasectomy in their partner as their form of contraception. All too frequently, when my patient says that a vasectomy is their form of contraception, we see her back for a subsequent pregnancy that she did not intend. Certainly, there are several barriers to completing this procedure, such as finding the time for an appointment, fear of pain of the procedure, and getting time off work, et cetera. These barriers may be valid, but patients shouldn't also have to face the barrier of a lack of insurance coverage. As already stated, a vasectomy is commonly performed in an office setting with local anesthesia. It's very effective with risk of pregnancy about 1 in 2,000, and potential complications are overall low, which include hematoma or a small bruising, infection, and of course, failure of the procedure. The cost of a vasectomy ranges from $350 to $1,000. In contrast, a procedure that I perform called a tubal sterilization for patients with gynecologic organs can be completed in 3 different ways. One of them is during a cesarean delivery when the abdomen is already open. The second is in the immediate postpartum period after a vaginal delivery through a small incision that's about 3 inches in the abdomen, or laparoscopically at any time unrelated to a delivery. In all of these cases, this is an abdominal surgery that carries the risk of a hernia, blood clot, vascular injury, bowel injury, and urinary tract injury. These are all inherent to abdominal surgery. In the case of a laparoscopic tubal sterilization, this requires taking on the risk of general anesthesia as well. Tubal sterilization these days mostly is completed in the form of a salpingectomy. That's where you remove the entire fallopian tube. Data estimating the risk of pregnancy after a complete salpingectomy is preliminary, but it's so close to 0, it's hard to put a percentage on it. Overall, the cost of a tubal sterilization can be up to $6,000. Vasectomy has a lower risk for serious morbidity and mortality than any of these 3 types of a tubal sterilization. And then also, independent of all these statistics and information, vasectomy is a form of contraception and therefore should obviously be included in mandates that require coverage for contraception. This bill also supports bodily autonomy and reproductive justice, which is something that should be enjoyed by every patient regardless of their sex.
Thank you, Doctor. That's the end of our testifiers. Are there any members of the audience who wish to testify? Before we go to member comments, I'll just point out that the 62J does demonstrate a very nominal, small cost per member per month impact to the plans. And I couldn't agree more that a vasectomy saves downstream health costs in multiple ways. Other member questions or comments on the bill as amended? With that, the motion is of Senator Wickland that Senate File 1054 as amended be recommended to pass and re-referred to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, we're almost there. Senate File 1085.
Do you have an A2 authors amendment, Mr. Chair?
Senator Seeberger offers the A2 authors amendment. All in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann.
Thank you, Mr. Chair. Senate File 1085 is a really important bill that will put all hands on deck when dealing with the maternal morbidity and mortality crisis we have in this country and in this state. Maternal mental health disorders are a leading cause of death among pregnant and postpartum women, with suicide as one of the primary drivers. I know we've heard this before, but the U.S. has the highest maternal mortality rate among other developed nations, with the economic burden of untreated maternal mental health disorders reaching $14 billion. If we treat maternal mental health disorders before they escalate, we can prevent catastrophic outcomes and cut healthcare costs. So what Senate File 1085 does is to ask plans to establish maternal mental health frameworks that are sustainable and come from the top down so that everyone participates. These services are already covered, so we aren't asking for new treatment. Other states have done this with a lot of success. This will decrease morbidity, mortality, and will decrease healthcare costs down the line, and will absolutely contribute to societal good. With that, Mr. Chair, we have testifiers.
Thank you. Can Dr. Gassemi and Mary Troyer please come forward? Welcome to the committee. Doctor, please introduce yourself and proceed.
Thank you so much. Good afternoon, Chair and the members of the committee. I'm Dr. Sogan Gassemi. I'm a board-certified child, adolescent, and adult psychiatrist, and I'm the director of the perinatal program at MinnesotaCare, where we treat women who are pregnant and postpartum with mental health issues. I'm here to support SF 1085 because maternal mental health issues is a public health crisis. As Senator Mann had mentioned, the United States has the highest maternal mortality rate in all industrialized countries. Mental health conditions are the leading cause of maternal death, with suicide and overdose as the primary drivers. Perinatal mood and anxiety disorders occur in 1 out of 5 women. Only 25% are actually treated. What are the consequences? They're dire. So when maternal mental health disorders are not treated, untreated conditions can increase the risk of pregnancy complications. They can increase preterm birth risks, and they can impair infant bonding and attachment. As a child and adolescent psychiatrist, I see the downstream effects. So there are also long-term consequences to children when their mother is struggling and doesn't get the treatment she needs. What are those consequences? They can impair cognition, they can impact emotional regulation, and they could lead to increased behavioral issues. Untreated maternal mental health disorders are at high cost in Minnesota. It's been estimated that yearly can be costing Minnesotans approximately $326 million due to medical costs, loss of productivity, and increased social services. Despite these risks, screening and treatment remain inconsistent in Minnesota. Minnesota rates of screening in 2022 was approximately 10% across all plans, both public and private. Even when screenings happen, providers often don't know where to send patients and what resources are available. Minnesota currently actually has 705 mental health providers that are certified by PSI, which is Postpartum Support International, specifically for perinatal conditions. And they plan to train another 100 in April of 2025. What the problem is a lack of infrastructure. Minnesota has the opportunity here to lead the nation in fixing this. So what the bill is ensuring is standardization in screening and referrals, alignment with HEDIS measures, or quality measures that the payers already have published, training providers, and centralized referral network. This bill has broad support from providers, advocates, and frontline healthcare workers, including Minnesota ACOG, MMA, and MPS, organizations that firsthand see the harm caused by untreated maternal mental health conditions. So we're at a crossroads. We can continue with a fragmented system, or we can build a model that makes Minnesota a leader in maternal mental health care. As you will hear from our patient stories, moms and their families deserve improvement in our system, and they deserve better. I urge you to support SF 1085, and thank you for the opportunity to speak today.
Thank you, Dr. Gassimi. Can Kristen now please come forward? Ms. Troyer, please introduce yourself and proceed.
Good afternoon, Mr. Chair and everyone else. I'm sorry, I don't know how to approach you. I am Mary Troyer, and this is my husband, Harry Gottwald, and he has to come with me. This is our daughter, and I have a picture of her who passed away from postpartum depression that was not treated properly. We are the proud and happy parents of Stacy Ann Gottwald. We are also the heartbroken and sad parents of Stacy Ann. She took her life at the age of 41 on August 16th, 2016, due to maternal mental health issues. Her beautiful baby girl was 6 months old at the time. Stacy had a healthy, normal pregnancy and birth and was excited to be a mom. A few days after giving birth, Stacy was having severe anxiety, and it escalated to postpartum psychosis. She was not sleeping and had ruminating thoughts of trying to be the most perfect mom. With depression, sleep can be precious and fleeting. Stacy sought out many counselors on her own, had ECT treatments, and participated in the mother-baby program at HCMC. She was hospitalized 3 times, being admitted to their mental health unit, working so hard at getting better. One time, an insurance representative/therapist came to our home to evaluate Stacy because she had been to so many counselors. This therapist recommended acupuncture for her depression. Stacy tried it, and that didn't work. Stacy did not want to go back into the hospital because they did not know how to treat her perinatal mood and anxiety disorder and approached this from the mental health side. We don't recall Stacy being screened for postpartum depression by her doctor. The OBGYN office gave her a little pamphlet to take with, which was about sadness after birth and to come in if you feel down. There may have been a different outcome with Stacy if she had been diagnosed with postpartum depression early by trained professionals and then referred to maternal mental health specialists. We miss our vibrant and amazing daughter, Stacy. Every day, and our wish is to help every mother get the appropriate care that they need and so well deserved. We strongly support this bill that mandates coverage by health plans of maternal mental health screenings and for insurance companies to cover the cost of it. We thank you for listening, and we thank you for your time.
Thank you, Mrs. Troyer, and thank you, Mr. Troyer, for sharing your story. Appreciate your courage. Kristen Now, please introduce yourself.
Good afternoon. My name is Kristen Now, and I'm deeply grateful for the opportunity to share my story with you today. In mid-September, I discovered I was pregnant with my first pregnancy, and what should have been a time of celebration quickly turned into a mental health crisis. The panic attacks and depression that followed were debilitating, and my husband and I knew we needed help. We reached out to our OB, sharing our concerns about my growing anxiety and depression that were beginning to affect my daily life. While my OB was willing to help, she lacked the resources to guide us to the right professionals. We found ourselves struggling to navigate the mental health system, only to be referred to providers who, while caring, were not equipped with the specialized knowledge needed for perinatal mental health. 2 months later, my situation worsened and I was admitted into an inpatient facility after my mental health continued to decline. After a month-long stay, I was discharged and connected with Prairie Care, an organization that specializes in perinatal and postpartum care. It was through intensive outpatient treatment that I finally met other women who understood my struggles. These women, mothers and soon-to-be mothers themselves, did not judge me. Instead, they supported me, helping me realize that I wasn't broken. I was someone experiencing a mental health crisis. I was still deserving of love, care, and support. But I'll be honest with you, my journey to the right care was long and full of trial and error. Without being connected to professionals who understood the unique challenges of perinatal mental health, I know I wouldn't be here today. This is why I'm here, asking for your support to ensure that every woman who faces a mental health crisis during pregnancy or postpartum has access to the resources and professionals who can help them. It is crucial to provide the proper support during one of the most vulnerable and precious seasons of a woman's life. This is my story. It is difficult to look back and recognize the person I was just 4 months ago, but I'm grateful that I eventually found the care I needed. With your support of this bill, we can ensure that other women like me will have the resources and timely care they deserve when they need it the most. Thank you.
Thank you, Ms. Now. And can the testifiers make room for Sarah Gangelhoff, our last testifier? Welcome back to the committee. I'll have you introduce yourself one more time.
Thank you, Chair Klein, members of the committee again. My name is Sarah Gangelhoff, and I'm the Director of Advocacy and Innovation at the Women's Foundation of Minnesota. We're in support of Senate File 1085. We believe that increasing access to preventative health care, inclusive of mental and reproductive health, will support stronger health outcomes in all our communities. Pregnancy and new parenthood can be a time of beauty and stress, joy and pain, personal growth, and stifling isolation. I know you've heard this statistic before, but it bears repeating. An estimated 75% of women impacted by maternal mental health disorders do not receive the treatment they need. So they do what generations of women have done: suffer alone, often in guilt and shame, unheard and untreated, sometimes with tragic results. Minnesota's Department of Health maternal mortality update found that 20% of maternal deaths between 2017 and 2019 were caused by mental health conditions. The same report notes that mental health issues, including substance use disorders, as a cause of pregnancy-associated fatalities have risen when compared to other prevalent causes of death. This is not an issue that's going away. We have the opportunity with this bill to meet people where they are, to let them know that this is not theirs to struggle with alone, and to be the lifeline they need at this crucial time. Barriers into maternal mental health care still exist. Along with stigma and cost, accessing mental health care providers can be incredibly difficult to do on your own. In our 2024 Status of Women and Girls report, we found that approximately 80% of Minnesota counties have a shortage of mental health professionals. When health plans connect providers to resources, it breaks down the access barrier that challenges rural communities, communities of color, and those living in poverty. By encouraging screenings as a routine part of perinatal care, it removes the shame and stigma a patient might feel in asking for help, and increases the likelihood that emerging issues will be flagged earlier with life-saving benefits. As I've said before, investing in health solutions makes long-term fiscal sense and savings for healthcare systems. According to the Maternal Mental Health Leadership Alliance, maternal mental health conditions are the most common pregnancy and childbirth complication. We can guarantee that there is someone in your life, whether you know it or not, who has struggled with their mental health during or after their pregnancy. For them, and for all families, we ask that you support Senate File 1085. Thank you.
Thank you so much. Question for the author. It looks like in the original bill, it was maybe a directive to health plans to develop their own maternal mental health program. But in the amendment we adopted, it's a little more specific. It requires coverage of 3 screenings at various points during the pre- and postpartum period. Is that correct? It reflects the amendment?
Mr. Chair, yes, 2 screenings and then additional screenings as medically necessary.
Questions or comments on the bill from the committee? Senator Duckworth.
Thank you, Mr. Chair. Actually, would have a couple questions for Ms. Now, if she's still around, if that's okay. if that's okay, Mr. Chair. Thank you.
Senator Duckworth.
Thank you, Mr. Chair, and thank you for being here and sharing your experience. I have just a few questions for you. You don't have to answer any specifics or anything you're uncomfortable with, but I'm just trying to learn a little bit more from your experience and your perspective. First, would you mind telling me, was your experience sort of in the Twin Cities metro area, or was it in greater Minnesota?
Ms. Now, can you please introduce yourself for the
yeah,
record and then
sorry.
address the chair?
My name is Kristen Now. I live in the southwest Minnesota, and so I was receiving care in South Dakota.
Okay. Thank
Senator
you.
Duckworth.
Thank you, Mr. Chair. And did you have insurance coverage at the time of giving birth and afterward, or did you not have coverage, if you don't mind me asking?
Ms.
I
Now.
do I introduce myself again? No. Oh, sorry. Mr. Chair, I do have health coverage.
Okay. Mr.
Senator
Chair.
Duckworth.
Thank you. And so despite having health insurance coverage, did you find that you and your husband had to pay out-of-pocket expenses towards some of the treatment that you ultimately received to kind of help you overcome the issues you were dealing with?
Ms. Now.
Mr. Chair, it was not necessarily the health coverage, it was being able to be connected with the right kind of support. Navigating the system was really difficult. Again, I was referred to different people to help, but they didn't have the right kind of support for me.
Just one more, Mr. Chair.
Senator Duckworth.
Thank you, I appreciate that. When you were sort of eventually referred to or found your way to the right resources, or some of the resources that you did utilize, were any of them provided to you free of cost to your knowledge, or did they have to go through your insurance, or did you have to pay for some of those resources?
Ms.
I believe,
Now.
oh, sorry, Mr. Chair, I believe they had to go through my insurance.
Okay. Thank you, Mr. Chair. That's all I've got. Thank you.
Any further questions or comments from the committee? Senator Howe.
Thank you, Mr. Chair. And I guess my question, so going down that line of questioning, how would this, for someone that gets their care either in South Dakota, in an outlying, not in Minnesota, how would this bill affect those residents? You know, they're a resident of Minnesota, they may get their care outside of Minnesota, South Dakota, North Dakota, because they live on the border. How would this affect their ability to get that care?
Senator Mann.
Mr. Chair, just like any other bill we write, Senator Howe, this affects people getting care and living in Minnesota.
So,
Senator Howe.
thank you, Mr. Chair. So I guess if they go across the border and get their care in South Dakota, this still would not have guided them to the right place? Or is that what I'm hearing?
Senator Mann.
Mr. Chair, yeah, we can't make people in South Dakota do anything because our laws don't apply to them. The reason why we have this testifier, Senator Howe, is because her story is very similar and probably almost the exact same as people in Minnesota. It's an issue of when you are diagnosed with something, getting a referral to a perinatal mental health specialist is very difficult. Getting that connection is very difficult. Getting that appointment is very difficult. So her story illustrates things that people in Minnesota go through every single day.
So I just want to underscore that. I
Nope,
think this is.
nope, I'm sorry, you haven't been called on by the committee. Senator Howe.
Thank you, Mr. Chair. I understand that. I mean, we've kind of gone through this with my family, so I understand the need for it. I just wanted to make sure I understood that in her situation, this wouldn't have been effective in that realm. But if you'd have to be getting that care in Minnesota, so that's it, Mr. Chair.
I'll just
I'm
make a
good with
sharp
that.
corrective to that, which is I'm not sure what the circumstances were of Ms. Now, but it would be her insurer based in Minnesota, whether she received the care anywhere, that would actually be affected by this bill. Any further questions? Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Mann, for working on this really important topic. I have a question. I just want to make sure I'm understanding the bill as amended with the A2. And there, I think the language reads that the the maternal mental health program must require at least one maternal mental health screening to be conducted during pregnancy, at least one additional screening to be conducted during the first 6 weeks, and then it kind of continues. Is that requirement for the provider or the health plan? Or I'm just trying to understand like who is required to do those screenings.
Senator Mann.
Mr. Chair, so the idea is the screening is done by the provider, but we want a framework built by the plans so that the issue we find is that when we require providers to do something, it becomes very piecemeal. And so if we go a step above that and have it a requirement done by the plan, not only will we have the screenings be done, but then we also have the referrals. And we also have the attachment to mental health providers, which is something that one-on-one providers cannot do, if that makes sense.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Mann. So I just want to make sure I'm understanding. So how I just read the language is that the mental health program, which will be established by the health plans, must require these screenings. And so if we have health plan A, they're establishing their program, they're as a part of that program require the screenings. Do they require that screening from the providers that they're reimbursing or the patients that they're reimbursing? I'm just wondering who is that requirement being attached to, if that makes sense. I don't know if Senate Council has thoughts on that either.
Chair, may I say something? I think it's in line
Once
with
again,
the-
ma'am, you haven't been called on
Oh,
by the
sorry.
committee. Council.
Thank you, Mr. Chair. Senator Rasmussen. So the provisions of this bill attach to the health plan itself. The requirements are imposed on the health insurer. The requirement that we're talking about through the amendment that requires the screening done at this stage and then at this stage is still an imposition on the health plan to require the providers. For example, one way they could do this would be through a provider agreement that the health insurer has with their contracting providers in their networks. Ultimately, it's a requirement on the insurer. Thank you.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Mr. Hudala. So if I'm understanding that correctly, basically this would have it where the health plans, as a part of their contracts with providers, this would be potentially a requirement where they would say the providers must produce these screenings.
Mr. Hudala.
Thank you, Mr. Chair. Senator Rasmussen, yes, I think that's an accurate statement.
Doctor, did you have additional
No,
response?
I think that's exactly what I was going to.
Members-
And then payers already have HEDIS measures that they've rolled out that are benchmarks that are tied to preventative measures, and this would be in line with that as well.
Further questions or comments from the committee? Motion is Senator Wickland's that Senate File 1085 as amended be recommended to pass and move to the Committee on Health and Human Services. All in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, Senate File 1407.
Thank you, Mr. Chair. There is an A1 technical amendment.
Senator Wickland offers the A1 author's amendment. All in favor say aye. Aye. Opposed? Amendment is adopted. Senator Mann.
Thank you, Mr. Chair. Senate File 1407 is a technical bill that cleans up ambiguity in the current 62J statute. So as you may be able to tell, I spend a lot of my time in the legislature in the healthcare space, both in healthcare insurance and otherwise. And so from the moment that I set foot in the Senate, I have been interacting with the 62J statute. And what I have found is that it is very ambiguous. Whenever I have a bill that deals with healthcare, which is regularly, I speak with staff and I ask, does this have to go through the 62J evaluation? And I often get a mixed response because the language in the statute does not reflect the intent of the statute, and it does not reflect our actual practice. We talk a lot about transparency and efficiency in government, so I want to do just that with this process. So to be very clear, this bill does not change our practice. We will still continue doing our 62J reports as intended, as we should, but it will remove the current ambiguity that is present. It removes vague and therefore unused definitions. It creates a pathway for freshman members to participate in healthcare coverage legislation, which they currently cannot do, and there is no other statute currently in place that prevents a freshman legislator from participating fully in the legislative process, and it standardizes the process for everyone. That's it.
Thank you, Senator Mann. Would you be interested in sort of walking through the bill and sort of detailing for
Sure.
the committee what the changes
Yeah.
are?
So, Mr. Chair, in Section 1, it clarifies that the evaluations must describe a mandate's impact on MA and MinnesotaCare, and also clarifies that the mandates applying solely to these public programs don't need to go through a 62J process, because this process is for the private insurance market. It removes the two types of mandate bills that rarely go through the evaluation process and have been historically ignored through the 62J process because they're confusingly defined and very broad. Section 2 will clarify that the Department of Commerce must also consult with DHS to determine a mandate's impact on the Minnesota Public Health Care programs, and clarifies that the Department of Commerce has to publicly post all conducted evaluations on a publicly available website within 30 days, which is already done in practice. Sections 3 and 4 clarifies that only the incumbent legislators must notify Commerce or HHS chair. Because of that August 1st deadline makes it impossible for those newly elected members to make it on time. And it clarifies that non-compliance doesn't invalidate a mandate. Instead, if Commerce messes up or if a legislator messes up for whatever reason, they can do a retroactive report by December. And then Section 5, it requires Commerce to develop forms so that the whole process is standardized. And it's not just me walking up to Senator Klein yelling in his ear, I have some bills, I need to go through the process. And then Section 6 clarifies again that the mandate doesn't apply to MA and MinnesotaCare unless expressly stated. That's it.
Thanks, Dr. Mann, and we have Mr. Graves. Welcome to the committee. Mr. Graves, introduce yourself and proceed.
Thank you, Mr. Chair and members. Again, Bentley Graves from the Minnesota Chamber of Commerce, and thank you for the opportunity to testify. So the 62J process, which you've heard a lot about today, is one that has been in place in its current form since 2021, and that was a process that we were very engaged in. As you heard from my earlier testimony, our members, by and large, buy insurance for themselves and employees in the fully insured market, which is the market that is typically the subject of the legislature's regulatory authority in the mandates that are passed. And so we had worked in a bipartisan way with the legislature at that time to take a process that was actually already in statute and make it more usable and more reliable in helping legislators and stakeholders understand the trade-offs associated with the mandates that are brought forward. We're 3 years or so into this process now, and we know a good bit more about it now than we did when it first started. I think as I've talked to Senator Mann and the chair, it probably is a good time to take a step back and start to ask some questions about how this process could be better, how it could be more useful to legislators and stakeholders. We do have some questions, if not concerns, about pieces of the bill as it stands today. Having said that, ultimately, we want a process that does what it was intended to do, and that is to help educate legislators and stakeholders and help everybody understand, again, what the trade-offs are associated with this. So we want to make ourselves available to Senator Mann, to the committee, to any others that are interested in working in this to find a way forward on changes and updates and revisions to this process, as the Senator said, that will get us to that point. But happy to answer questions, and again, happy to work on that going forward. So thank you.
Thank you, Mr. Graves. Questions from the committee? Senator Rasmussen.
Thank you, Mr. Chair. And I do think the 62J process is valuable. And I remember, actually, this was what helped establish the 62J process, and I don't have insight into who the advocates were on the Senate side, but it was when I served in the other body, worked very extensively with Representative Elkins, and this was a bipartisan effort, where I think legislators on both sides of the aisle and probably both chambers felt that they didn't have the information they needed to really evaluate health mandates that were coming forward. And I think even the conversation today has really benefited from having 62J reports and knowing which mandates are effectively free, that they don't have costs for Minnesotans, they don't have costs to the states, and which ones do have costs, and then we can weigh those cost benefits as we go through the budget process. And I guess, Mr. Chair, the ask that I would have on this bill is that in spirit of the bipartisan bicameral work that went into establishing 62J, that we would have bipartisan bicameral work on any reforms happening to it. And I actually think Senator Mann in this bill has some good recommendations. I totally understand the impossibility of a freshman legislator being able to submit a mandate, before they even know if they have an election certificate. And I think there's some other things, tweaks that can be made that will improve the process. I would say my biggest concern is on narrowing the scope of what types of bills would end up going through mandate reviews. And then I also just have concerns as well on not requiring the bill text. Even when we get back some of the 62J reports, they will oftentimes talk about the uncertainty of, well, what does this mandate include? What does it not include? I think it will get back less good reports with less specificity if we don't have actual bill language to the Department of Commerce. And then lastly, I think this bill again brings up an interesting debate that we have had for a number of sessions, which is around, do mandated health benefits include or exclude public programs? And I think in here, this bill would make the default that they are excluded. And I would actually encourage the inverse, to basically have an assumption, unless it's stated otherwise, that public programs would be included as a part of the 62J process. So, Mr. Chair, I mean, you have my interest in this topic, I think others on this committee, and I'm happy to work with Senator Mann on the bill. But I would just ask the committee that we make this a bipartisan consensus-driven process, because the initial bill had that bipartisan bicameral work. Thank you, Mr. Chair.
Any response from the author?
Mr. Chair, you said a lot. I don't know if I'm going to be able to remember everything you said. But so nothing that we did today, for example, would have changed. So everything that we did today would have stayed exactly the same. All the bills we heard would have still have to have gone through the 62J process. It would not have decreased the scope of today's hearing whatsoever. The part about the bill text, what we are hearing from the people doing these reports is that the bill text changed so often with all the amendments that it's very cumbersome, and it changes the report. So the bill text is actually not helpful. And then the default, right now the default is that this does not include MA or public plans. So that also is not changing whatsoever.
Senator Mann and Senator Rasmussen, as we talked through that provision in particular, as you know, that's a point of some importance to me. It was represented to me, and I think I was convinced, that the 62J process excludes those programs, but we include them in our legislation, and that was sort of legislative prerogative. Can council speak to that provision within the bill?
Thank you, Mr. Chair. Just to clarify, you are referring to the provision that the default would be that it does not apply to the MA program. Correct. So that provision specifically says it does not apply to medical assistance fee-for-service. I would note it does not say that it does not apply to medical assistance managed care. That provision is an attempt to codify existing law and practice. The way that the Department of Human Services and our drafting practice historically is operated is that if we pass a mandate in Chapter 62Q or 62A, it is interpreted that it will apply to medical assistance managed care, and this just restates that. I would note I can't speak to the virtue, what's better, the inverse or this, but my understanding of the intent when this was drafted is that it is also easier to draft it this way and not then when you pass a mandate in, say, Chapter 62Q, have to remember that and then refer back to 256B and kind of negatively carve those out, it's easier to use an approach, as Senator Klein alluded to, legislative prerogative to affirmatively add it to the MA chapters. That's my understanding of the intent of why it was drafted that way.
Senator Rasmussen?
Thank you, Mr. Chair, and appreciate the context from Senate Council. And, you know, if we're thinking about 62J, like one of the ways that we could strengthen it, and many of the reports we had today did talk about public cost impacts. And so we could just make clear that as a part of these reports that we want to have information included on public program impacts. I would say in response to Senator Mann's comment, you know, I do think that this does in a meaningful way change the scope of what is evaluated. And I think we heard that same concern from Mr. Graves from the Chamber of Commerce, where if we look at the bottom of page 1 going into page 2, a whole bunch of plan design parameters, including cost sharing, benefit design, treatment for disease condition, a type of healthcare treatment or service, provision of medical equipment, supplies, or a prescription drug used in connection with treating a particular disease condition or other care need, imposing limits or conditions on a contract between a health plan and a healthcare provider, such as like network sufficiency or other things. We're taking a whole bunch of language out of this bill. And that's my main concern, is that this will be narrowing the scope of what will go through the 62J process, and will ultimately then have more bills that we have less information on. I think as a part of this process, we should err on having more information to help us make our decisions and not having less. And I worry that the scope changes here will result in fewer 62J reports to help inform our decision-making.
Thank you, Senator Rasmussen, and I'm just going to respond to that because I had the same concern when I saw all the deleted language at the bottom of page 1 and top of page 2. What I was directed to, and what I'll direct you to, is that the substance of what we consider mandates, you must cover this drug, you must cover this treatment plan, you must cover this medication, is contained above in lines 1.13 through 1.20. What is being deleted is specifically those phenomena as they are incorporated into a particular benefit design. So the mandates, again, that we heard today are still required to be processed through the 62J process. I would say almost every mandate I've heard proposed this year would still be required to pass through the 62J. What is deleted is a particular benefit design that includes those conditions, and I haven't seen a lot of legislation that is structured that way. Senator Mann, is that your understanding as well?
That is correct, Mr. Chair.
Senator Rasmussen.
Thank you, Mr. Chair. And I would guess, I would say, then why are we deleting the language? What's the problem with that definitional language and leaving it in if it's so rarely used? And I do think that oftentimes some of the bills that come for here, for example, many today have talked specifically about eliminating cost sharing for items that are already covered by insurance. We've heard, feedback that, for example, vasectomies are covered by our plans currently, but what the bill did was eliminate cost sharing, and that's some of the language that's being deleted here today. So it's not actually about whether something is covered or not, it's how is the cost distributed between plan members and the plan itself. So I would just, my feedback would be if it isn't changing anything, why are we changing it, would be my concern. Thank you, Mr. Chair.
Thank you, Senator Rasmussen. And I would also take to heart your admonishment that this was a bipartisan, bicameral phenomenon that developed, and we should adhere to that principle as if we're going to revisit it. And so this bill has 2 more stops, I think, state government and HHS, and I encourage the author to pursue those conversations as we move forward. Further discussion by the committee. Senator Wickland.
Just a comment, Mr. Chair, that the part of the process to evaluate the cost to our public programs happens through our fiscal notes. So if the bill gets moved to the HHS committee and we submit a fiscal note request for it, we will get that public program cost impact. So it's not, I don't think it's going to be left out of the process. So.
Further questions or comments? Seeing none. Senator Mann, you made it through all, was it 6 bills? Congratulations. Senator Seeberger moves that Senate File 1407 as amended be recommended to pass and refer to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Motion is adopted. Committee is adjourned.